Please join me in welcoming Senator Bill Frist.
All right, well, good morning, and it's great to be back in the Twin Cities, and Governor Dayton and I spent so many nights together, so many days together, talking in a bipartisan way across the aisle, in a contrast to what we just heard this morning, but also with a greater aim, a greater good. To be able to work side by side with the governor and then to have him introduce me is a huge, huge honor. What I'd like to do this morning is spend time with you making a transition from what you just heard in terms of politics, the divisions, the chaos, the coming at each other, and make that transition from government to innovation, to creativity, to dynamism, to much of what this conference is indeed about. And I really want to begin with, why do politics matter, especially to health? And politics do matter. With all of that chaos, with all of that conviction never coming together and that working across the aisle, why do we vote? Why do we participate? And politics do matter. And I'd like to talk a little bit why and then move to innovation. First and foremost, government, when focused, can do incredible things to move our health, not just health care, but our health forward. And again, we have health care, which is sort of the 15% impact on overall health and burden of disease, and the hospitals, and Bill Frist, the transplant surgeon, and the doctor. But as we look at the overall health and well-being, government is the main leverage point today. And I think I can give you two quick examples. Number one would be PEPFAR, this whole AIDS initiative that we put together about now 15 years ago. And the second one will be the whole initiative of the Human Genome Project. So PEPFAR, again, this is an example of why government matters. That government can do good things, even in a partisan environment, by coming together. When I was an intern, HIV/AIDS just barely existed. In fact, in 1983, it was the first time 5 cases of HIV were identified in this country. Those 5 individuals died. It was a case study from the West Coast. 2 years later, when I was a resident, about 10,000 people had died, and 2 years after that, 1 million people had died. And then by the time I came to the United States Senate, 3 million people were dying every year of a little tiny virus, a cagey little virus. No country in the world had successfully addressed this virus at that time. Most of the people dying around the world were vulnerable populations in Africa and in Haiti around the world. But a right-wing president, I say that affectionately, George W. Bush, who had never traveled to Africa, worked with Republican leadership. I was majority leader at the time, the only doctor in the United States Senate, and Democrats across the aisle in this initiative called PEPFAR, the President's Emergency Plan for AIDS Relief, came together. And as it came together, legislation was passed. It was in that early 2000 State of the Union message, a surprise announcement that this country, on behalf of the American people, in a bipartisan way, under the leadership of President Bush, would begin an initiative that would change the history, as written in the textbooks, of public health. It indeed has saved, since that time, 20 million lives worldwide through what is obviously known as the largest humanitarian relief effort in history, the single largest commitment for a single disease by any country in the history of the world. By about a 3-paragraph piece of legislation, the leadership of the American people. So government, and nobody else could have done it. And the United States led, and through that leadership, 20 million people are alive today that would no longer be alive. Another example is one that I was close to, very close to, in the year 2000. And that's when we announced completion of the Human Genome Project. This is why government matters to health, why government matters as we make the transition over the next 30 minutes or so to innovation and entrepreneurship and capitalism and the sort of things that you've really come to this conference to learn about and to talk and to discuss and to network about. That example of the Human Genome Project, really, really interesting. 1990, a bunch of people came together, scientists and government officials, and our United States government said, over the next 15 years, we're going to do something that has never been done ever in history and won't be done unless government does it. Again, we go back to just an hour and talking about the chaos and the partisanship and nothing getting done. Things can get done. So in 1990, they came together. They said the human genome, wait just a second, if I do this, hundreds of thousands of cells are coming off my hand. You don't see them, but if I picked one up, that cell has your entire genetic code, every one of those hundreds of thousands of cells. We didn't know what the genetic code was, and now we do. 3.2 billion bits of information in every one of those cells that are coming off my hand because of the government initiative, government coming together with the best scientists, the best universities in the world. The Human Genome Project was supposed to go from 1990 to 2005. In the year 2000, when I was in the United States Senate, I was with that group of scientists and universities and public officials to announce that the human genome, all 3.2 billion bits of information, had been defined 5 years earlier than anticipated. And in 1990, it was projected to cost about $4 billion to be spent over those 15 years. Not only did it come in a shorter period of time, but it came in under budget at $3.7 billion. Now, did government do it? No, it's kind of like innovation and what brings all of us together. Government doesn't do it, but it takes the leadership role. It sets the tracks. It has the regulations. It puts the vision out there. And then 70% of the research is not government scientists, but it's the universities and research scientists all over the world coming together, working within that framework. Government matters. Voting matters. Don't get too discouraged and walk away, because 20 million people are alive today, by example number one, and there are 2,000 medical diseases that have been defined, genetically defined, because of that project. There have been about 2,000 let's say 20,000, and there are about 20,000 new genetic tests today because of the Human Genome Project today. Government matters. Shifting again to innovation, again, all of this creativity and science that came out of the Genome Project, all of the lives saved of HIV/AIDS, the cost of therapy used to be $10,000 to treat somebody with HIV, down to $400 or $500 because of the great scientists that were called together. Government matters. But all of that innovation came from this government matters introduction as I lead from what you've heard the last 2 hours to innovation. Innovation means lots of things to lots of people. So the teacher in me and the surgeon in me basically said, let's keep it really simple. And most of you come to this conference and with the discussion of knowing what innovation is. I, as a surgeon, like to classify things in very, very simple terms. That's why I didn't go into medicine. That's why I didn't go into other areas of science. And basically, when I look at innovation, I say, what is good about innovation? Innovation in and of itself is not that important. Again, it's important, but only if it can be taken to scale, only if it can be executed on, only if it can disrupt an existing system to lift people up in the healthcare field and have them live healthier lives and more fulfilling lives. And therefore, the criteria I go back to again and again when I hear a speaker, and if you don't have your own criteria, use these 3 criteria over the course of today and tomorrow. When the venture capitalists talk today and talk 2 days from now. And I use 3 things, and number 1, I use these graphics, and these are based on Clayton Christensen, which all of you know, who does a lot in terms of steel mills and disruptive behavior. We want disruptive innovation because America is full of innovative ideas, full of great ideas, but until we can deliver and make them disruptive, they're not gonna have the impact at scale when it comes to health, of lifting people up, not just health care, not just making health care better, but actual health, the overall well-being of an individual. The first I say for today is enabling technology. You want to have some kind of technology today with disruptive innovation that makes lives easier or does a task easier. In that category today, I would also include access to big data, because we know, and people are struggling with how to use big data and how to accumulate data and how to translate it, put an app on it so it's actually useful. But is there technology, number one, in this innovation? Number two is innovative business model. And by an innovative business model, I go back to the Christensen sort of overall approach, and that is, do you have a model that can be modeled out that will reach, for example, new customers? As big companies get bigger and bigger, they tend to go for sort of a middle income and an upper income because that's where the money is. So Clayton Christensen will say go after sort of people who are forgotten. The more important thing to me about the business model is have a model that has the potential for going to scale, to bring new people to the table, to bring new money to the table, to bring resources together. And the third point is a whole, and it's a good symbol for it, a coherent value network. Come back to the value. It used to be 5, 10 years ago, it could be an inventor or an innovator making a product that benefits the consumer, and that's enough. And in some cases, that is enough. But for disruptive innovation, I would argue, for example, in the healthcare field, I started a company called Aspire Health, palliative health care. I'll say a little bit more about that shortly. It's a fascinating field that takes people with its serious advanced disease in the last year of life. Not hospice, not the last month of life, but the 9 months, 10 months, 12 months before that. It's a chaotic period. It's an expensive period. Your mom in the middle of the night calls you, a state away and says, I've fallen. What do I do? I don't know what it was. I have some chest pain and I'm by myself, or I have an asthma attack. What do I do? And then goes into the hospital. There's no hospital record. They repeat a bunch of tests, comes home. The same thing happens a month later, 3 months later. People in America don't die if they have serious illness the way they want to die. If they go in and out of clinical trials needlessly because that's the thing to do. So we took people in that last year of life and we said, we're going to identify you. So if there are 200 people in the room now, we'll identify which 5 of you need it. Don't try to promise this sort of care to everybody. Wrap a team around those people, a doctor, a nurse, a palliative care specialist, a chaplain, a yoga specialist, whatever it takes to make that last life work. There, again, coming back to the analogy, the enabling technology was the fact that we had the analytics today because of big data to identify which table in this room is the table that needs that care. We don't have to spend money on everybody else. The innovative business model is that last year of life is expensive, is chaotic. So if we make it less chaotic and less expensive with higher outcomes, all of a sudden costs go from $80,000 a patient down to about $50,000 with better outcomes, better well-being, more satisfaction, higher net promoter scores. And the current value network, which is what I really want to emphasize, is that it's not just the patient who benefits, but it's the doctor, it's the palliative healthcare doctor that before Aspire, which is community health, palliative health care going to scale, that palliative care doctor who went into medicine was just doing consults all day long, every 15, every 30 minutes in a hospital. That's not what they want to do. They want to practice care and watch them get better and stay with patients over time. Another little prong off that number 3 there would be the payers. The payers are paying $80,000 for hundreds of thousands of patients every year, when in truth you can get better outcomes for $50,000. So the payer actually benefits. Another problem would be the patient's family. The patient's family, all of a sudden, when they get that phone call, know that a 24/7 doctor or nurse will see their mom and not just send them to the hospital, but make sure they're appropriately cared. So the family themselves benefit. But anyway, you get the feeling, hopefully by that example, of how you can use these 3 points again and again over the next several days. Now, this is very, very selfish. I'm going to use sort of a family company that I've never actually worked for, so there's a lot of distance to it. But in this picture, it's called Hospital Corporation of America. It's 50 years old. It's the largest hospital company in the country, probably the second largest in the world, and it's been the largest in America for 50 years because it continually innovates again and again and again. I call it a disruptor for lots of different reasons. Before HCA came along, again, 50 years ago now, there was no company in the top 100 companies in America that was a healthcare company. No insurance company, obviously, no pharmaceutical company, no hospital company, no healthcare company in the United States of America was in the 100 of the Fortune 100 companies. Today, they're 18, and healthcare is 19% of our economy. But why was HCA such a significant disruptor in the industry? It took sort of a nonprofit industry for the most part and said, we're going to inject business principles that focus on the patient. Remember, most hospitals were a cottage industry. They weren't affiliated. There was no Kaiser. There was no Vanderbilt medical system all across the state. So HCA came through the profit investor-owned motive, brought professional managers in instead of some nonprofit local citizens who volunteer for a hospital board to run hospitals, and that's where it came. But what it took is the guy on the left is my dad, who died about 20 years ago, and he was the culture. He was sort of the value that the third point I made was Christensen's disruptors. He was the value that showed benefit to the patient and the culture of being a physician and caring. The middleman there, Jack Massey, where did he come from? Jack Massey was the first person to take 3 companies public on the New York Stock Exchange, and he also started Kentucky Fried Chicken. So he was that sort of business. This is how you model it. And the guy on the right is my brother, who was 29 years of age when he started. He was the innovator. The others made it happen through the Christensen model. Why is healthcare, why these next 3 days, yesterday and today and tomorrow, why are they so important? It's because the field is ripe of health, again, not just healthcare, but health is ripe for disruption. Why? For 2 reasons. High cost, $19,000 for an average healthcare plan for 4 people. And uneven levels of access are the 2 reasons that healthcare, from a health service standpoint, are so ripe for disruption. Not just innovation, but innovation that can cause disruption, change the way things are done. To go from a fee-for-service, process-driven system to one that really is truly value-driven. So why haven't we seen more disruption? The barriers are higher today. And again, on this slide, I just say back in 1968, the healthcare industry had lower barriers to entry. Healthcare then was local. You had one hospital that didn't affiliate with another hospital or share services or make bed linens cost a penny instead of $100, for 12. The scale was just unheard of. I mentioned in 1968, there were no healthcare companies in the top 100. It was just an easier place to be, and then Medicare and Medicaid came in 1965. The resistance to change that we've seen that we are overcoming now in 2018 that we really weren't in 2015 is why I'm so excited. It's why I start healthcare companies in the venture capital world. It's why for the last 12 years since leaving the United States Senate, I've participated in building about 40 countries at the private equity level. Obviously, we all know it. I'll go through these quickly. They're misaligned financial incentives. You just don't have the incentives in healthcare. It's like Uwe Reinhardt, my former professor at Princeton, who died this past year. It's like shopping with a blindfold on in a grocery store. You don't know what the prices are. You don't know what's going to benefit you. I mentioned price transparency a little bit lower. It's just like shopping blindly. The patients really cannot influence design very much. Most of what you'll be talking about over the next 48 hours is going to be innovation, consumerism. First panel tomorrow is going to be all about consumerism, and I believe in it. I think having 300 million people driving the system, making choices every day is much more powerful than Bill Frist, Majority Leader of the United States Senate, saying this is the way it's going to be. It just is. But in truth, consumerism does not exist in healthcare today. And again, a huge overstatement. But if we look at the curve, and the panels tomorrow morning will talk very much about where we are and how we can explode consumerism. And one of the drivers, obviously, is the fact that deductibles have gone from what they used to be 15 years ago, $200, $300, $400. And for the employer-owned market, or employer-driven market, which is 50% of healthcare, deductibles now are $1,500 and $2,000. And when it's your money, it's going to drive the consumer. Innovations traditionally in healthcare, unlike the iPhone in my pocket or the computer prices or anything else in technology, in healthcare, innovation typically has driven cost up, driven spending up. true innovation, true disruptive innovation. It's no longer the case, but you look at the CAT scans, which came along in my era. Now there's a CAT scan on every block or every 2 blocks. A powerful, innovative machine, critically important to what I did. Heart transplants, critically important to cancer, which I used to operate on. Absolutely vital. But as you can imagine, you're picking up more disease. You're picking up more false positives. Each one of those scans costs anywhere from $400 to $2,000, depending on whether you're in a hospital or outside a hospital. And that means that great disruptive innovation didn't do what most people think or what the economic textbooks drive down the cost of health care. I mentioned lack of price transparency, but economists always write about Bill Frist, the heart transplant surgeon who knows how to take hearts out and put them in new people. I did it weekly. It took me 15 years before I did my first heart transplant. I'm studying every day, every night, 8 hours a day. That gave me a body of information that the patient coming in did not have. And that's not a bad thing, it's a good thing, or used to be a good thing, because I could transmit that information, that experience to that patient, take out their heart, put in a good heart, and give them another 30 years of life. So that's a good story. But a much more powerful story is that today, unlike 5 years ago or 10 years ago or 15 years ago, patients are empowered with as much information as a physician has. They don't have the experience, but can walk in with asking the right questions, demanding the right response. And this explosion in consumerism that we are going to see, with all the different decision makers shaping the system in a positive way, built around value and outcomes, we're just on the precipice coming forward. I mentioned high entry cost, again, answering this question, why there's been this resistance to change. Todd Park and Ed Park, the guys who did Castlight and Athena Health, and I'm participating with them and other people who started a company called Devoted Health. Devoted Health will sell its first Medicare Advantage plan in Florida this week. But what it's taking on are the big systems that have been in the Medicare Advantage world, that's in Medicare, the managed care world, which is 60 to 70% of Medicare today. The systems it has to take on and beat and compete with a new company, a startup company, Devoted Health did not exist a year ago, are big. Humana do great work, and United, who do great work. So to be a disruptive innovator, which we are, because what do? We put consumerism first. These big companies have net promoter scores of 10, 15, that sort of approval, consumer approval moniker that many of us use. And we want a net promoter score of 60. Number two, we've got good technology. Number one, in terms of looking at innovation coming in Devoted Health, we'll have the best technological people writing the software programs anywhere in the country. And the whole point is that we're small. We're a disruptor, but we have to overcome the competition, which has high entry costs, legacy institutions, and complex regulatory systems. So innovation in healthcare has been a challenge. Unlike in 1968, disruptive innovators in healthcare today are going to need government. Again, my whole job is to link what you heard 2 hours, an hour and a half ago, and link it to this unbelievable world of innovation and creativity and dynamism, which can shape healthcare, which in my mind goes back to the picture of Dad, when I used to go on rounds with him as a young boy and see walking into a dark room with a patient lying in bed on a house call, when he came in, their face brightened up, a smile come across just because that person is there. It gave them hope. In today's time, unlike 20 years ago, 30 years ago, government is important. And when you think consumerism, again, I'd encourage you, you can think Airbnb, and you can think Netflix, but in truth, it doesn't apply. Why? Because 50% of all healthcare runs through government today. And that's not true with West Coast ideas of consumerism. Government matters. We got to participate. We got to vote. We got to get the sort of leaders there who understand what all of you naturally understand. And we have that opportunity to do just that. The second reason government, we're not an Airbnb, we're not sort of the classic consumerism, is that we are a highly, highly regulated industry. Uber is not. Uber is not. They went fast, they went furious, they didn't pay attention to regulations per se in the transportation. Housing, Airbnb is not a regulated industry, healthcare is, and it's appropriate that it is. And when you talk about politics and how much regulation there is, it becomes interesting to talk health care. Is regulation good sort of top down, or is it better to be designed locally with the input of the actual players that a United States Senator and a President of the United States just don't know? You just lose touch. No matter how smart the 435 House members and the 100 senators are, you're just not as close as communities in rooms like this for writing those regulations. Government, again, matters. So now that I've said that very quickly, how do I see it 2018 over the next 4 years? Innovation, especially disruptive innovation, will occur in 3 areas. Number one, in Medicare. Medicare now is probably $60 or $600 billion. It's big. It's probably 60 million people. And if you put Medicare together and Medicaid, and then the tax deductions you get for insurance, as I said, about 50% of all healthcare dollars do flow through government. The innovation will occur, the first one I'll list is Medicare, and it'll occur through the Medicare Innovation Center primarily. I say this because I know Secretary Azar very well, and I know Adam Bowler very well, who runs it, and I know and Seema Verman, I spend a lot of time with them. That's where innovation is going to occur. It's interesting that I'm a Republican, but a lot of Republicans wanted to kill it because it was an Obama entity. But now, under the current administration and the current leadership, innovation will occur. Adam Bowler, who many of you may know, I think is unbelievable. He came from the private sector. He started a small company. It grew fast. It focused on a population of advanced illness, serious illness, chronic disease, where we know most of the challenges healthcare are. He put that company together using a risk model, using terminology. He sold it, and he immediately dedicated the next 2 years, 4 years, I don't know how long, to serving our country at CMMI. And that's where you'll see the innovation come. It's where Secretary Azar will be channeling that innovation. The second one I have up here is Medicaid, or the states. The Republicans, as long as they're in control, and again, I think the House will go Democratic. I think the Republicans will keep with the Senate. And I think, I won't go any further with projections because that was for the first talk. But no matter what sort of it is, you will see an attitude that the federal government coming off Obamacare doesn't know how to solve the problem. And again, I'm a big advocate for a whole lot of what we saw in Obamacare. And I do think that a country as wealthy and as rich as ours, and all of you and our companies do have a responsibility, as James said, in some shape or form, whether it's through risk pools or insurance, helping the underserved. So I fundamentally believe that. But how do you best do that? It's going to be determined more at the state level. At Governor Dayton's level, at Governor Haslam's level in Tennessee, and it'll be through Medicaid programs. It's not going to be a one-size-fits-all. So if you're going to innovate and you want disruptive innovation, do work with your Medicaid programs. They'll have the flexibility to focus on local needs. The last thing I'd just mention is the 21st Century Cures Act. It is the act that did pass in the lame duck session, but did pass with a divided Senate and a House. And it was a big piece of legislation, and it set the template for personalized medicine, for example. And you'll be talking about personalized medicine, that you won't have one drug for everybody in the room. You'll have one drug at the right dose for a group of people, depending on what their genetic code is. Again, pulling back to my opening on the Human Genome Project. And that framework to use for the next 4 years comes from a piece of legislation that was passed by the people who are currently in Congress today, in a lame duck period, but currently in Congress today, which shows good legislation has the potential for being passed, even in this chaotic, sort of disjointed Washington, D.C. that we see today. All right, so in just 10 minutes, well, I'll do something that's really fun, I think, again, as we make this little trip from government, why it matters, the importance of regulations, the Christensen principles, to what we're really about the next 3 days. And then after I finish, you can take it away for the next 2 days. Let me just give you some examples. Number one is this company, Aspire. 5 years ago, based on my transplant experience, I left Mass General in Boston after I did my residency, after my sort of really 15 years of training. I left because Massachusetts General, man's greatest hospital, that's what they used to call it, Boston has all the legacy. Many of you are probably from Boston. They said no to innovation. They said no to heart innovation. There was this new procedure called a heart transplant. And we didn't know it, we didn't have it perfected, but we knew we had the immunology. If we put a heart in, they could live, but we had work to do. But Boston, in its political correctness wisdom, I don't know what to call it, I think made a huge mistake and said, we're putting a permanent moratorium on heart transplants. So as a young resident, I left there and I went to the West Coast. I trained with a guy, Norman Shumway, innovative, California style, came back to Nashville, started a transplant center, and then all of a sudden I started getting referrals of sick people because I was one of the few people east of the Mississippi doing heart transplants. And all of a sudden hundreds of people started coming in, all of whom were going to die within 6 months. I'm a heart transplant surgeon. I move hearts and organs around. I don't know how to take care of people well, of chronic disease well, because I wasn't trained to do it, so I hired teams of people to do it. And we took care of all those people waiting for a heart transplant because I didn't have enough hearts, and all of a sudden they started living longer and healthier lives and more fulfilling lives, which showed me there's something to a team-based approach around advanced illness. I went to the United States Senate, lost my mind, went to the United States Senate, came back at the United States Senate, and then 5 years ago started this company called Aspire Health. I've already told you the story itself, but let me say on the slide what I have. Actually, let me back up one time. So Aspire Health, just look at don't try to read all these slides. I'm obviously not talking from those talking points, but at the top is about a year of a patient's life with severe advanced disease. The clinical model without Aspire, which is in most of America today still, because this is a new company. I started a company 5 years ago. I sold it to Anthem about a month ago, about 2 months ago, so they could take it bigger. Because I, again, want to go to scale, and there's only so much that I and our team can do. The last year of life, you have life-prolonging care. You have a, say, 70-year-old woman who has chronic obstructive pulmonary disease. The last green month of her life, she might be in a hospice, which is appropriate. You get good care. All of us have unbelievable experiences. But that blue part, that last year, we talked about it, it's chaotic, it's expensive. People don't get good care. They're going in and out of offices, and they're on 13 to 14 different medicines which conflict. And what we did is actually Aspire in that lower with our clinical model. That whole year, we come in with our team of patients, wrap it around a patient, and with that, they stay out of the hospital, their costs go down, they're with their family, and it has all the advantages that we talked about. It fits the Christensen model perfectly. Example number 2, this is a fascinating one that you may not have heard about, but again, it comes back to why government is important. It gives the framework. It has the safety and efficacy. Scott Gottlieb, I give an A+, currently runs the FDA. And he has a lot of experience. He has the knowledge. He has the common sense. And so I mentioned that to the side because we've got Alex Azar, unbelievable guy. Adam Bowler, unbelievable guy. Scott Gottlieb, unbelievable guy. Unbelievable people out there at the top in healthcare today. So here's the problem. There are 10 million people with diabetes. Diabetes has affected every one of you, either with a child or a parent or a relative. And depending on how you define diabetes, it's 10 million or it's 20 million or it's 30 million people. But let's say there are 10 million people with diabetes. 40% of them are going to develop a diabetic retinopathy in the eye, a diabetic, common sense, retinopathy. When you look into their eye, the blood vessels are squeezed down and there's plaque in them. The problem we have today, the system works at about half of those people who will get diabetic retinopathy. By the way, 24,000 people go blind every year because of it. Half of those people, the diagnosis is never made. And why is it never made? All sorts of reasons. But currently, if you're diabetic, you'll go to the primary care office. They'll say your blood sugar's up. You need an eye exam. You look in, what your primary care doctor does. They only get it right about 60% of the time. So they'll send you over across town to an ophthalmologist. 2 weeks later, you'll go in, she'll dilate your eyes. You sit there. The ophthalmologist will look in your eye, and with about 90% accuracy, still not 100%, will be able to see a picture like this and say, oh, you do have diabetic retinopathy. This is what you need to do to either reverse it or to keep it steady so you won't go blind. But all of this being referred, dilated your eyes, have another specialist look in your eyes, the cost of it, the inconvenience, having to wear sunglasses for the next 2 days. is replaced by this company by going, and I'll use an example, to your primary care doctor. It could be a CVS, sitting down for 2 minutes in a machine. The machine comes, it takes picture without dilating your eyes of your retina, and then it goes to the cloud, and with artificial intelligence, compares it to millions and millions of other scans whose clinical outcomes are part of that. And using artificial intelligence comes back, you leave CVS or you leave the doctor's office with a machine-driven autonomous diagnosis built on artificial intelligence. Now, I tell all that story because the FDA, the first device ever to be approved for autonomous artificial intelligence, is this little company that I've been involved with for about 6 years called IDX. Again, it's innovation, it's disruptive, it has the technology. I just told you what the business plan is to take it to scale. And the beneficiary is, yes, the patient, but the patient's family, the healthcare system, the doctors, the cost of the healthcare system. It fits the model perfectly. A third example is a Teladoc. And this is a company I helped take public about 2 years ago. And it's a publicly held company. All of these companies I've either started or on the board of or invest in. In academic world, you're supposed to put all that on a slide, but just so you know, all of these are things that I'm involved with. But they're good examples because these are the only kind of companies that I choose because I use those three criteria. And Teladoc is an interesting one in that 2 weeks ago, I was speaking at a conference and took my wife, Tracy, with me, and we were in Carmel, which is a beautiful, beautiful place. And while I was doing all my work all day long, like all of you are doing, she went to the spa. I had to bribe her a little bit to go with me, so I said, you're going to the spa. About 10 o'clock that night, she developed a little sty in her eye, and a sty is a sty. You don't treat a sty with anything. You put hot compresses on it, they'll all resolve over 3 days. But then at about midnight, all of a sudden, the whole upper eyelid got red. And then I said, oh gosh, I don't know, but a little inflammation. And then about 2 o'clock in the morning, the lower eyelid got red. And then I said, I'm smart enough because I've had kids, growing up. I'm a doctor and I love heart transplants and I love doing thoracic surgery and I love all that stuff. But you don't want to doctor your own family. And especially a heart surgeon doesn't know that much about eyes. And so I said, what are we going to do? 2 o'clock in the morning, Carmel, no hospital close by, clearly no drugstores. And I said, oh, yes. So I pulled out my iPhone. 4 clicks later on Teladoc, 4 clicks, that's all, 4 clicks. And 3.5 minutes later, at 2 o'clock in the morning in Carmel, a doctor popped up. That doctor on the iPhone was California board certified, was a primary care doctor, and she said, basically, I see it, because I showed Tracy's eye, and he said, can you just take 3 pictures? And I said, what do you do that? And he said, look at your phone. He said, just push 1, 2, 3. And I pushed 1 picture, took a click, 2. He instantly got it. And he said, Dr. Frist, what I would tell her, he told Tracy, what you need to do is be on doxycycline, and you need to be on within several hours. That thing that you thought was a sty is probably Staph aureus with 90% certainty based on the pictures you sent me at 2 o'clock in the morning. And then he said, oh, by the way, the doxycycline you can't get right now in your neighborhood, but if you drive 3 miles, here's the address, and I will call them right now, and you can get your doxycycline. Now, I tell that long story because it just happened to me 2 weeks ago, but it's what Teladoc is all about. That same story went on 35,000 times that day. There'll be about 2 million visits just like that. The cost of that is about $40. It cost me $40 to do that. If I'd gone to the emergency room, the cost would have been around $1,600. On average, for something like sinusitis, very common, people going to the emergency rooms, allergy season, that on average cost out of an emergency room about $2,400. The option is a $40 click at your home, or that night we were in a hotel, not driving 2 hours, not sitting in an emergency room with a bunch of people who are sick, and then seeing a nurse, and then a doctor, then being given a prescription and having to find a clinic at night. And that is the value system of an entity like Teladoc. It currently has 40 million members, 24/7 in every state in America, has 95% member satisfaction. Now, again, I won't kind of march you through all criteria, but the high cost of health care, which we all know, and the uneven distribution, in other words, access issues of being able to get people in a convenient, affordable way, it's ripe for disruption. Not just devices like IDX, but in the health service industry. Now, I'm sorry. In this chart, don't try to read all of this, but we started Teladoc with just that little kind of thing in the left-hand, a little icon, general medical. That's just what I told you. But in the business plan, the number 2 of the Christensen principles, it said that's good, but once you get to 3 or more million visits a day, again, 4 million visits, saving $1,000 every visit, huge cost savings to the system. It goes to that third bullet of, you gotta have a lot of beneficiaries itself. Then all of a sudden you start filling in. And again, you probably can't read these, and I'll just walk across a few of them. We expanded into pediatrics, and then we went into the behavioral health care, which I'll come to in a minute with my last example. And then we moved to Ask the Expert, where you can just call and talk to anybody, and it'll be one of the board-certified specialists in that field, all the way to overall virtual medical home over on the right. The whole point is going to scale starts with very simple technology, but organized in a way that can increase access to people in a broad way. Teladoc is the largest virtual care system in America today, and very soon will be across the world. Again, 4 years ago, 5 or 6 years ago, really a small, tiny little company that basically linked a doctor to an individual, now in the comprehensive care business and virtual health care. Let me, and I'll stop with here, then I'll show a little video, and then I'll disappear and let you go on to your day. Health care and health, and this program that you have from MANOVA is really organized beautifully if you look through and participate. The burden of disease or the cost of health care or health has 5 determinants. One is your environment, and that probably is a 5% sort of impact, maybe 8%, depending on where you live. The second would be socioeconomic, how rich you are, your zip code. I'm on the board of the Robert Wood Johnson Foundation, and we preach zip code where you live, and it's important. And when I have that hat on, I say it's the most important thing, but it doesn't give you action items of where to act, where you're going to act if you want to change healthcare, make it more efficient, make it more productive, make it more effective, lift individuals up. So say 5% environment, 15% is the socio-economic, 30% goes back to where I started, the genetic, the human genome, the thousands of tests, the thousands of disease, that code of billions of bits of information. Each sort of strand of DNA is about 3 feet long if you take in each of these cells that you stretch out, and what that defines about, it's about 3 feet high if you do that, by the way, and it's in every cell. It's just so hard to imagine. And every cell has your entire genetic code for it's just amazing to me. Government matters. But that whole genome issue, genetics determines about 30%. So 5%, 15%, 30%. Now, where I've been talking up to now, and so I want to extend it and close with it, is the 15% of Bill Frist, the heart transplant surgeon, IDX, retinopathy, advanced care disease, Teladoc, telemedicine, and that's the system. Insurance company, Obamacare, Clinton care, and all. But the real impact on health and well-being and cost is in that 40% that's left, and that's behavior. And behavior is broad, I know, but as you continue over the next few days, be thinking about how we can link the 15% of the health care complex stuff that I'm a part of or been a part of. How can you put a big circle and pull in that 40% that is in behavior? Because then you have 55%, and then you have a huge impact on changing the health of your child, whether or not they have a disease 5 years from now, 10 years from now, and the health and well-being of 8 billion people across the world, when you can start doing that. So behavior, as it suggests, is this. And again, let's see here. You don't really need to read this, but let me tell you what virtual reality is. What is it not first? Virtual reality, and the bottom line, jumping ahead, is that I'm unbelievably excited about virtual reality. This is one of the companies that I believe in and sought it out. It's hugely powerful in changing behavior. What is virtual reality? It's not just a digital extension of an existing media, which is what people think that it is. Virtual reality is experiential. It's the experience that's made to feel like it's real. It is possible today, unlike a year ago, in part because of the gaming world, but in part because of technology. Facebook announced 2 weeks ago these Oculus headsets. You no longer need a computer. You don't need your iPhone. You don't need an app. It's self-contained. It'll sell for, I don't know, I didn't look at it, but sell for $300, and it'll be out next year. So this fall in the price is going to make it much, much more available in the behavior field to address people who are at home, who are by themselves. And what do you want to do? And we all know, I fly, and many of you may fly airplanes. Simulation in flying is really powerful. You can give me a checklist of what you do and what you don't do, and from a cognitive standpoint, you know that checklist and you can memorize it. But not until you're put in a simulator and your reality, which is not real, you're digitizing your reality, but it feels like it's real, and that changes behavior. It is demonstrated again and again in other industries that that's the way you change behavior. In our life, experiences are much more powerful than Bill Frist with a white coat coming in and say, you've been smoking for 30 years, you may get lung cancer, do not smoke, and here are 3 reasons why, and then leaving, hoping that the cognition itself will have the impact, and it doesn't work. We can get people to smoke, but that is not the way to do it. So what this experiential or experienced reality in virtual reality, the closer it can get to reality is the way we learn. It's the way our brain learns. We don't fully understand why, but we know our life experiences teach us lessons better than reading a book. And it's as simple as that. And here I say virtual reality experiences, and it's important because they will educate you, because we want to change that 40% of behavior. It'll motivate you. It'll activate healthy behavior. And as I said, unlike prior media, virtual reality is an experiential exercise, not a cognitive one. And in the last bullet there, I just say, it has been demonstrated to treat psychiatric conditions, acute pains, neurological disorders, provide physical rehabilitation, all of which has been demonstrated. I could go on and on about that, but let me just take you to that world of virtual reality.
BraveMind is a treatment option with appeal for today's digital generation. BraveMind gradually recreates trauma-relevant scenarios that clinicians can use to help patients confront and process difficult memories in a safe and supportive environment. More than just sights and sounds, BraveMind uses a virtual reality head-mounted display, directional 3D audio, vibrations, and smells to generate a truly immersive recreation of the event that can be regulated at a pace the patient can handle.
We help people to go back to the things that they were traumatized by, help them to confront those things, to face them, to talk about them. By this process of doing this repetitively and over time, what you see is a gradual decline in the anxiety or the fear response.
Well, what could be a groundbreaking new treatment against opioid addiction is happening in Nashville.
Isn't this wild? Wow. Virtual reality is helping addicts tap into the source of their addiction. News 4's Edward Birch explains how it works. New at 5. Edward?
Tracy and Tom, here at Vanderbilt, inside this building known as the Wondery, a grad student is using virtual reality to tap into the psychology of an addict and help them face their addiction. Noah Robinson is a clinical psychology grad student at Vanderbilt.
What we're looking at is basically can the virtual reality be an immediately accessible intervention?
Robinson believes virtual reality can help patients tap into their negative feelings and find the source of what's fueling the addiction. Patients can talk to their therapist while in the VR world in the form of an avatar. Robinson says this can be a more proactive and outside-the-box approach to dealing with addiction. If this works, many believe this can fight the opioid epidemic.
The long-term goal is to eventually get these headsets in the homes of patients. If you can create an intervention that is as accessible as the drug for the patient, that perhaps they can choose the intervention over the drug.
That's it. 20 years in medicine as a physician with a dad and a brother who kind of are on the forefront of creativity and innovation, which continues today. Of 12 years in the United States Senate, where I went as a citizen legislator to go for 12 years, not stay forever. And thank goodness I didn't coming in. And then the last 12 years, this is just what I do. And I love the opportunity and appreciate the opportunity to make that bridge of why government matters, why we can't give up on that with the big picture. Walk through the model that I use as I create these companies that you've seen and many other companies through an entity called Frist Cressy Ventures. And it really does come back to the reason that all of you are here. Innovation and creativity and energy and dynamism, and that's really what this conference is all about. The principles I use are the three I put forward. Use whatever you want, but underneath that, I understand, I know you understand, the real mission is to lift up the health and well-being of every single, leaving nobody behind, every single American. Thank you all, and it's great to be with you. Have a great conference. Really appreciate it. Thank you. Thank you.
Thank you. Wasn't he great? Terrific.